So could we go to the next slide? I hope you all are healthy and safe during this meeting. As we gather to conduct Delta business, whether in our homes for virtual meetings or in physical venue, it is important for us to always be Delta ready. Please take a moment to identify two exits in your current location. Knowing where the exits are is essential for an efficient emergency evacuation. Additionally, during this post-COVID-19 pandemic period, please continue to adhere to the public health guidelines of your local community. Stay safe and always be Delta ready. I'm Sora Marsha Johnson, and I am the chair of the Physical and Mental Health Committee. Tonight, we are joined by 5 esteemed women in the mental health realm. They are Terry O'Dashiel, Latoya Congolo, Dr. Linnell Plummer, Maisha Rice, and Dr. Karen Smith. Tonight's moderator will be Annapolis Alumni Chapter and PAMH Committee member Joanne Scipio. Our chapter president, Deidre Peters, will bring greetings to our guests. Soror President, I turn it over to you.
Thank you, Sora Marsha. I appreciate that. Greetings, sorors, esteemed panelists, and cherished guests. It is my sincere honor to welcome you on behalf of the Annapolis Alumni Chapter, Delta Sigma Theta Sorority Incorporated. I am Deirdre Peters, and I have the privilege of serving as chapter president. May is Mental Health Awareness Month, a time to illuminate, educate, and activate. Today, we boldly step into that light. Our theme, Breaking the Stigma, Seeking Mental Health Treatment in Our Communities, aligns with Delta Sigma Theta's 5-point programmatic thrust, specifically our commitment to physical and mental health. This thrust calls us to promote wellness, raise awareness, and confront the disparities that continue to impact our communities. Today's gathering is a direct extension of that charge. Together, we are shifting the culture, one conversation, one breakthrough, one brave step at a time. Welcome. Let us continue the sacred work of healing, advocating, and uplifting together.
Thank you, Soror President. Soror Scipio.
Thank you, Sora Peters. Our panel will bring individual perspectives on breaking the stigma of seeking mental health in our communities. Our first panelist is Terry O'Dashiel. She is the director of Lightbridge Health Office of Community Health and Wellness and M. Peter Moser Community Initiatives. Ms. Dashiel has over 30 years of experience as a nurse, and in addition to her dual directorship, she currently practices as a community health nurse educator and certified health coach. Nurse Terry, as she is known by many, previously held certificates in acute care nursing, perioperative nursing, and practiced in the areas of clinical education and quality improvement. She has appeared as a guest speaker on several occasions, including Lightbridge Health Ask the Expert radio broadcast on WBAL TV, Weekend Health segment, Relaunch, Best Practices to Reopen Churches, a nationally shared live webinar on faith-based organizations after the COVID-19 pandemic, and most recently as a panelist for the 24th National Population Health Colloquium on Defining Healthcare Access, Embedding Care to Everyday Spaces. Her practice has often led her to work in many community organizations, including Delta Sigma Theta, welcome Soror, of which she is a member. She has a passion for teaching about health, wellness, and disease prevention to all who receive the message for better health. And so that is, see her, okay. Our second panelist is Latoya Congolo. Mrs. Congolo is an award-winning mental health expert and entrepreneur who has served Anne Arundel County in various roles for nearly 2 decades. She was the social and emotional chair for the Anne Arundel County Board of Education Citizen Advisory Community, where she successfully advocated for increased mental health services for students. As a former county employee, Latoya played a key role in developing effective programs to combat the opioid epidemic while efficiently managing budgets for these initiatives. Her leadership in program development extends to county courts, detention centers, and hospitals. And she has collaborated with the last two county executive administrations, state legislators, and county council members. Latoya has partnered with the City of Annapolis Mayor's Office to create the Naptown Antidote Movement Program. In addition to her contributions, Latoya received the Distinguished Leadership Award from Leadership Anne Arundel County in 2020, the Legislative Black Caucus Excellent Leader Award in 2022. Just recently, Latoya was appointed to the Maryland House of Delegates on January 10, 2025. And since being appointed to the Maryland House of Delegates, she was named the 2025 Legislative Rookie of the Year, 2025 New Leader Honoree by Leadership Anne Arundel, and was selected to serve as a Maryland State Director for the National Organization Women in Government. And Latoya is also a member of Delta Sigma Theta. So welcome, Sora, again. Our third panelist is Dr. Laniel Plummer. As a leading professional in mental health field, Dr. Laniel Plummer and her team of 30 Black women of color are committed to improving the lifestyles of others through the aspects of mental health, education, and coaching. A United States Navy veteran and the CEO of the Onyx Group, an organization she founded in 2013, Dr. Plummer has over 18 years of working with a multitude of clients and specializing in the care of young women, the Black community, and the members of the LGBTQ community. Her work and expertise has been featured in everything from TED Talk to Essence, NBC, Forbes, The Washingtonian, and Time Magazine, among others. And she has spoken at conferences during the Essence Fest for Mental Health America, NYU, and the U.S. Black Chamber of Commerce. Additionally, she is a recipient of several awards, including the Lifetime Achievement Award, Gathering Spot, the BOW Nose Growth, 2023 Titan Gold Award, and Who's Who 2024 International Marquee. Currently, Dr. Plummer is finalizing her first book, The Essential Guide for Counseling Black Women. Our fourth panelist is Maisha Rice. Maisha is a native of Baltimore. She's trained and licensed to diagnose and treat mental health and substance abuse disorders. Maisha earned her Master of Social Work in Clinical Mental Health from the University of Maryland Graduate School of Social Work. She also served as a 2013 keynote commencement speaker, where she received a roaring speech on behalf of her graduating class. Upon graduation, Maisha worked and volunteered in various settings, including the Baltimore City Public Schools system, adults with co-occurring addiction and mental health disorders, military veterans, homicide survivors, and individuals and families with complex trauma. She has worked within the criminal justice system with the reentry population and has served as the first African-American female to oversee program operations for the Adult Drug Treatment Court for Baltimore City's Circuit Court. And our fifth panelist is Dr. Karen Smith. Dr. Smith is a native of Southern Maryland. She's a family physician with a private solo practice in the rural community of Rayford, North Carolina. Dr. Smith completed Hahnemann University School of Medicine and did her residency at Duke. She chose to start her professional practice of medicine in North Carolina. She recognized the needs of the people and reached beyond the examining room and became involved with the North Carolina Academy of Family Physicians, as well as the North Carolina Medical Society. She is actively engaged with the American Academy of Family Physicians. In addition, she serves on the North Carolina Medical Society Board of Directors and as a state delegate to the American Medical Association. Dr. Smith has participated on numerous committees and boards throughout her career, and most recently enhanced her professional basket of services, providing treatment for substance abuse disorders, healthcare reform, and improvement initiatives, and on-site education experience for learners in healthcare. The practice of Dr. Karen L. Smith has been selected as one of 3 leads the EOPC entities which will engage primary care and their patient and their partners in systems redesigned to promote greater equity in healthcare. Her heartfelt interest in global medicine is demonstrated with mission work abroad and support for educating and training doctors worldwide. Dr. Smith has been recognized as the North Carolina Family Physician of the Year in 2016 and the American Academy of Family Physicians in the year 2017. So you see, we have a broad scope of practitioners that well qualified to deal with this topic in such a short period of time, and we welcome all of them. Okay, we will be asking our panelists several questions that will give our audience food for thought of how they can break down the stigma obtaining treatment for mental illness and the fight for the right to claim heightened mental health. Afterwards, we're going to invite the audience to post questions in the chat so the panelists may have the opportunity to address them. Now, we know with so many specialists, they won't all be able to speak on every question. So we're going to start with one question. Since this is about stigma, we know there's a stigma attached to mental health. Can you define the stigma and what are some of the barriers associated with seeking mental health? And I want to see who wants to take that first chunk. I can call on you.
Good evening. I'll start. I want to say good evening, everyone, and I'm glad to be here. I think this is a topic that we all really need to discuss so that we can take it back and empower our friends and neighbors. So when it comes to mental health, the stigma that you refer to is often described as people, especially our patients, as the shame or disgrace that surrounds them or they feel that surrounds them when it comes to either their circumstance, their background, or just how they are as a person. So when we discuss barriers associated with seeking care when it comes to mental health, the stigma itself can be a barrier. Other barriers can be those that we in healthcare hear about a lot, which could be a shortage of known practitioners, the inability to reach a provider due to transportation, sometimes insurance issues. Another barrier related to the stigma is that people are just not in a space where they feel safe to talk about their mental health, or they've been diagnosed in the past and they have a hard time accepting or owning or living with the diagnosis, similar to what you see when people receive a physical diagnosis. I think fear is a huge barrier. Many people are afraid to even acknowledge there's an issue and definitely afraid to seek treatment.
Yeah, and I'd like to add to what Mr. Shield said. First, I want to say that I'm excited that Maisha is here. She and I graduated from the School of Social Work together in 2013, and I was there firsthand to witness her dynamic speech at our graduation. So it's good to see you, Maisha. What I want to add to it too is that we have to consider the cultural aspect. In our culture, it's been often overlooked, not talked about, being judged as or being criticized or being called crazy. But I'm because I'm in this field, maybe I'm biased because I look at this as healthcare in general. But for me, I feel like if you've never sought therapy, then that does make you crazy because of the fact that we're all strong until we're not strong. And what we need to do is just look at this as we would healthcare. If you go to your doctor and get an annual physical, if you see your dentist every 6 months, your head is connected to your body. So if you're not taking care of your head, you will physically break down. So I feel like part of the stigma is that we don't look at this as we do any other form of healthcare.
Okay. Anybody else want to quickly say that? And we'll move on to the next question. Looks like Maisha has her hand up.
Oh, yes. I just also wanted to say that stigma, it comes from a lack of understanding and fear, and it paralyzes us to be able to move forward and actually seek help. And I feel that if we focus on really what the word stigma means in medicine, which means a visible sign or characteristic of a disease or a mark or spot on the skin, if we kind of simplify these definitions versus us actually having a stigma, I think we would be able to move forward, a lot better, because we're actually viewing those with mental illnesses in a negative light because of our lack of understanding and fear.
Okay, great.
And if I could jump in real quick, good evening, sorors. How are you all? I agree with everything that I've heard all the experts say and want to be able to add a little bit more in as well. So like we heard just a second ago, stigma is really defined around disgrace and shame. And so when we think about disgrace, we're also saying that there's a lack of grace, there's a lack of compassion, there's a lack of understanding. In the Black community, particularly with Black women, we haven't been allowed to give ourselves grace. We've been socialized to continue to push forward. We've been socialized to minimize anything that causes discomfort and pain. And so our socialization based off of our intersected identities as Black people and as women creates or allows for more shame and disgrace to be there, which emphasizes the stigma. Some of the barriers that we're experiencing are some of the things that we often know, such as access to care, access to high quality, insurance not covering. There's also things that are very much centered on our cultural experiences as Black women that are also barriers. And so for some of us, if we go to church and we go to a church where the pastor and the deacons are not well informed around mental health, that can create a barrier because we believe that we have to pray this mental health issue away as opposed to getting the treatment. God made the minister, God made us, God made therapists too, right? He made your dentist too, right? So when you go to your dentist, it's because you need some treatment. When you go to your therapist, it's because you need some treatment. So one of the barriers is church and the perception there. Another barrier that we're seeing in the community is around social media and experts. There's a lot of folks that are on social media, on Instagram and TikTok, telling everybody what they should do if they have a mental health issue, but they're actually not licensed to be able to provide any mental health or healthcare support. So people are relying and dependent on people who are not actually experts, and that has created a barrier. There's a barrier that's connected to the perception of severity. And so folks, historically, as you wrote the question, specifically around baby boomers and Gen X, those are we all grew up post-war. And so at that time, there was a lot of idea that people with mental health issues had to be very severe. Our clients that have schizophrenia, or they're delusional or hallucinating, and they're not necessarily considering that a lack of severity in that diagnosis also warrants mental health services. A person may just be having trouble making decisions, and that means that they can also benefit from mental health support as well. So those are just a few things that I wanted to add in from a cultural perspective that's not always captured in the data when people are asking about why Black people and Black women aren't going to therapy.
And if I may, since we're all going to take a turn on this one of the things that we can do to stop propagating stigma is stop labeling. If we stop labeling behaviors and problems, and I'll give you a good example. Many people will say diabetics. Well, no, those are individuals who have the disease of diabetes. So when we label diseases, conditions, and traits and behaviors, that propagates and that adds to the stigma associated with these conditions.
I think that you're muted, Soror.
Oh, sorry. I think we all got a good definitions of stigma. So maybe we can reach out to the community, the ones on this call, and help get rid of that stigma. Because as Sora Latoya said, it's health. It's all about health. It's just like we have the physical health, we have the mental health. So we'll go on to the next question. I don't know if we'll be able to let each one of you answer every question because we'll never get through and we'll never have the opportunity for our audience to participate, but that was a great way to start off. This question, once a person has a mental health diagnosis, once they're diagnosed, can that be a barrier in other areas of their life, such as employment, insurance, and relationships? And since Dr. Smith was the last one to speak with the least amount of time, I'm going to ask her to check in on that one this time.
It can be a barrier, particularly with employment. If an individual discloses that they have a mental health condition, they are automatically thought of that this individual may not be dependable. Their cost for the health insurance may be higher, that we actually may see their condition manifest itself in the workplace setting And so there's so much that's brought into that. So it can be a barrier. I'll have our other colleagues elaborate, but that's certainly what we see in an employment setting.
I could jump in if it's okay. So while it can be a barrier, like Dr. Smith is saying, it doesn't necessarily have to be a barrier. It's really a matter of what the framing is, right? So just like we used the example a second ago with someone that may have diabetes, just because they have diabetes doesn't mean that they can't work. Just because someone has depression doesn't mean that they can't work. However, they may need additional accommodations. They may need additional support. They may need letters from their therapist or from their support services to be able to identify what their capabilities are. So the label itself can be a barrier, but oftentimes it doesn't have to be. It's really a matter of the framing. And in therapy, that's where we really help the client to understand what that framing should be. We're helping to provide emotional vocabulary. We're helping to talk about different protective factors that need to be in these different environments so that their mental health is not causing an issue at work or in their relationships. And we're also helping them with the development of coping skills. So the label itself is really supposed to be used as a catalyst for treatment. It's supposed to be used so that we understand how to make that treatment plan, what interventions are supposed to be on there to be able to label what symptoms that a person is experiencing but has never had the vocabulary or the experience to express. It's also, the label is also supposed to be designed to be able to help people understand who they are and what they're experiencing. It doesn't necessarily have to be a permanent label. So again, going back with what Dr. Smith said, it can be a barrier, but 9 times out of 10, it really doesn't have to be. And it doesn't have, and we can really circumvent a lot of those situations as well. So please, if you're listening, do not be afraid that this label will create a barrier in your life, in your employment, or in your relationships. Just like your health issues does not create a barrier, mental health does not have to create a barrier. But come to us for support so that we can give you the language to use to be able to make sure that you are able to elevate your life experiences through this label and not to feel that it is a barrier for you.
Okay, we're still on time, so if the other ones want to jump in just for a quick comment.
Sure, I'll just really quickly. One of the things that I often do with clients is teach them how to advocate for themselves and know what their rights are. Because, employers, we want them to look at mental health as a way to increase performance on the job, just to kind of give them the positive aspects of it. If a person is mentally well, they're more functional, more reliable. So, a lot of employers are, in my experience, need that education and they're starting to recognize it. And, it helps decrease that stigma or that fear of disclosure in a client. So I think it's incumbent upon us professionals to advocate and then, help people self-advocate so that way that they don't have that fear and they can utilize the EAP or any other resources through their employer.
Like to add that sometimes in the community, what I see is it often depends on the person. I've met people who feel like their diagnosis helps them in life. There are those who feel like ADHD makes them good multitaskers. There are those that, like Dr. Plummer mentioned earlier, who have seen or kind of bought into what they saw on TikTok and YouTube, and they feel that they can make their diagnosis their superpower. They can place themselves in the right circumstances where they can use their diagnosis to their advantage. I've met a woman who says that her boyfriends like her better when she's manic. So she doesn't take her meds so she can stay fun and impulsive. I've also met people, however, who feel that in the workplace, people that know about their condition either bully them, gaslight them a lot, or treat them like they can't do anything because they're aware of their condition. Where I see a lot more problems, one of the things that we have to remember is that we're not just looking at an individual that's dealing with a mental illness issue, but also the individuals around them. So there are countless moms, spouses, siblings, and others who have a really hard time in life due to the perils of living with those who are untreated or who cannot follow their treatment regimens. And you see a lot of that and how that affects people out in the workplace. At least I do, out in the workplace and out in the community, a little bit more than you actually see what happens sometimes with the person that's dealing with the mental illness.
Okay, thank you. Aisha, would you like to add anything to that? Don't want to leave you off.
Oh, no, ma'am. With all of what was said.
Okay. Don't have anything else to add? Okay. Just for the participants, if you have questions, you can put them in the chat, and we can also look at those too if we get through the questions we have here. Okay. Our next question is, should mental health checkups be a part of the routine physical examination? And if not, is there an ideal time to seek a mental health checkup? So should they be a part of the routine physical exam? And if we say no to that, is there best time to seek mental health checkup? And Maisha, why don't let's start with you, since you
Yes, ma'am. Sure. I believe that they actually are a part, the screenings, the questions that are asked are actually a part of our annual, physicals and checkups. I do believe that we do need to do a better job with screening and having annual screenings for mental health. And that's one of the things that I actually do with my practices during the Mental Health Awareness Month. I offer free screenings so that people can do as you would do for breast cancer or prostate screening. The same thing should be done with mental health, because you just never know. Times change, life changes, and you never know what criteria you may meet for a mental health disorder.
And we do use the PHQ-9, which is a screening tool for depression, the GAD-7, a screening tool for anxiety, as well as alcohol use, as well as opiate use or other substances. And we use that on a regular basis. Some individuals are familiar with what's called an annual wellness visit, which every Medicare patient should be completing every year. And at that time, we screen. When our young children are coming in and they're of a certain age, we screen with portions of the tools similar to that of the PHQ-2. So screening is done quite a bit. In screening, we use those same questions to also monitor the effectiveness of the medication and the treatment that is being administered. It is so important to screen. And one of the questions on the PHQ-9 is, have you ever thought about attempting to take your life or hurt yourself in some way? If we just ask that question, do we know of how many of these mass fatalities and shootings that have been done if somebody would just ask the question? And the last part that I would say, many people who have committed crimes of this nature or who have done something just out taking life of another or taking their own life, they have encountered the medical community, the psychiatric community. They typically have encountered someone, but we didn't ask the question. So we need to make it a habit. Ask, how are you doing? And run that PHQ-9 or GAD-7.
Yeah, Dr. Smith is absolutely right. I can tell you that, one of my favorite sayings is, consider it a checkup from the neck up, the checkup from the neck up. We get a checkup when we see any other healthcare provider. Why not get a checkup from the neck up? And it's important because we can catch it before it becomes a crisis. So when Dr. Smith talks about someone who acts out violently or, some other extreme circumstance, if we're able to do some sort of early intervention, catch it before it becomes a crisis, and now our society is bleeding as a result of it, then a lot of these issues can be avoided if we just simply get a checkup from the neck up.
If I am able to add on, I will also say that I do believe that mental health checkups should be part of the routine physical exams. And I think that it should also be separate. So I do think that because our society is very much conditioned with going to a physician at least once a year for their checkups, then those medical providers should be able to do different checkups and ask different questions and use some of the assessments that Dr. Smith referred to. However, I think that there should be an additional step with that, particularly because mental health therapists are designed, are created and trained to be able to do deeper dives into mental health as well. So where physicians may be doing some of the assessments like the PHQ, a therapist or even a psychiatrist in that nature could do more broadband assessments. So we have to be careful because some of the assessments that are done at the physical health check-ins are looking for very specific symptoms and they're looking for very specific disorders. But sometimes there could be a misdiagnosis in that process if there's not a broadband assessment that's done. And so what looks like depression could actually be trauma. What looks like anxiety could actually be something else. And so taking that next step after you've seen your physician to go and see a mental health therapist to take a deeper dive is going to be especially important as well. And like Sora Latoya said, just like we go to the dentist or just like we, go and get our eye exam, we should also be getting a specific mental health exam every year. And it could be preventative in some of the more extreme cases like homicide or suicide, but it can also be preventative in some of the things that we kind of take a little more lightly, like divorce. If a person is getting those annual mental health checkups, they can also be able to describe if they're having any issues in their relationships, if they're having any tensions in their relationships. It could also be preventative in ensuring that we're not creating or continuing generational traumas. So it could also be preventative in making sure that we're living a life of our dreams. And so again, people often think about mental health in the more extreme forms of the diagnoses, which are true, but it's also in our day-to-day functions and how we live. So having those annual checkups or maybe even those checkups every 6 months can be really helpful in intervening on some of the life circumstances that we don't necessarily want to experience.
Terry, Nurse Terry, did you want to add anything to that?
I add one thing. When we talk about the questionnaires and the assessments, those of us who are raising children or those of us who are taking care of our parents, it's imperative that we let them answer the questions, especially when it comes to what Dr. Smith said. Our idea of how our children feel or how our parents are doing is a lot different, and we need to let them answer the questions and let them complete the questionnaire so that the practitioner can get a true picture of how they feel and what's going on with them mentally.
Okay, thank you. And with the physical and mental health checkups, like sometimes we see it as Dr. Smith said about the elderly, the Medicare that is required, but the other areas is not always necessarily the physician sometimes just kind of run through that very quickly or somebody else asks the questions. And we see particularly maybe with the baby boomers and Gen X generation, there's more shame and extra shame in that group in seeking out mental health care. And what can we do about that? Do you have any comments on that? Any of you? Because that's a particular group that we're concerned about, that they're the ones that don't get the care, because we make sure that our young children, we make sure our kids go to the doctor, we make sure the older people, they have all the illnesses and aches and pains, so they go to the doctor. But that in-between group, how do we make sure that they get the care, and the shame that they're faced with, how do we address that? Who wants to tackle that one? Latoya, I see you shaking your head. So.
Yeah. I mean, my first thought in hearing your question is that we have to consider the generation. We're of our generation, it's more accepted. So I personally, if it were me, I would not use the term mental health, mental illness, or because that will probably turn off someone who is of a generation where that stigma is still there. And I think that it's better to just kind of talk about life changes. I think it was maybe Dr. Smith or Dr. Plummer who mentioned divorce, retirement, just some of those life circumstances that may affect us and change the way we function. and kind of normalizing those situations and approaching it in a way that that normalizes it and say that these are real feelings. We're human beings. This is the human experience, and these feelings are real. And that doesn't make anyone any different or any weaker if they experience those feelings.
To say that it goes back to me for what Dr. Plummer said earlier when she touched on generations a little bit. In our communities, our boomers and Gen Xers are more likely to have been discouraged by family and friends, either directly or indirectly, from what we've heard them say about other people, um, to talk about and seek treatment for any concerns with mental health, whether it be generational. Like many of us are often reminded of the strength of our ancestors, right? And how they endured atrocities and in the past under circumstances that make our lives seem like a cakewalk. So what are we complaining about? We've been told, we've been raised, what happens in your house stays in your house. So don't talk about anything. Telling your business is frowned upon. Historical reasons, like a general mistrust in the health system that ranges from having to deal with providers of all levels who lack cultural competence, being labeled as mentally unstable, even if as a patient you decide to question your doctor or bring up a different treatment path that you heard about. A lot of us have been trained and taught, as Dr. Plummer mentioned too, to turn to God. And if you don't, your faith falls into question, leading to punishment through more illness to test and rebuild your faith and also the faith of those around you. Those are just some of the reasons where we look, because generationally, compared to our younger generation, they are quite free in talking about mental illness. They feel like they found their tribes. They will self-diagnose and tell you what's going on with them mentally. They have a whole treatment plan based on what they saw on TikTok. So those are some things that we take into consideration when we look at the difference in our generations.
I agree with both Terry and Sora Latoya as well. I think that it's important to you whenever we're talking about generations, we have to use the language that is important to that generation. And so if we use language that is outside of their generational understanding, then it becomes a turnoff. It becomes a challenge for them, and that creates an additional barrier. They think that they won't be seen, right? If we don't even use the language that they use, they're like, how are you going to understand my perception, my perspective? How are you going to understand what my generation went through and what this means to us? I think it's also important for us to consider what is the culture of that particular generation. Each generation has its own culture. There's a way that they communicate with each other. There's a way that they relate to each other. There's a way that they see themselves and see others. And that becomes a formation of their core beliefs. And once we understand the culture of that generation and we understand the general beliefs of that generation, then we can enter into that conversation using some more of that specific language. So again, thinking about baby boomers and Gen X, which I'm proud to be a part of, we came out of war. And so many of the baby boomers lived through different wars. Many of Gen X lived through different wars. And so again, to Terry's point, there's a perception that because we have a life that's different than those that came before us, that they don't necessarily need mental health. So it goes back to what I was saying before about using life transitions as a matter of encouraging people to go into therapy. Like Sora Latoya mentioned, there could be retirement. There could be a new baby in the family, whether it's your own or a grandchild. There could be, moving and relocation. All of those things fall into one of our disorders called adjustment disorder. And so that could be the easiest way that someone can get into therapy, by just helping them to understand that the transitions that they're experiencing in life, whether they're positive, can also still have a loss or can also trigger something that they've lost in the past. So highlighting where they are in life, what their transitions are, as well as using language that is aligned with their culture based on their generation.
Thank you. Okay, we'll move on to our next question. And I think we've kind of touched on this somewhat. So we'll, if anybody has anything to add to that. We say people often can confuse mental health with mental illness. And so how can we make people understand the difference in the two? Because sometimes when we're talking about mental health, and I think somebody already said, when you call it mental health, they think in terms of mental illness. So how can we define it, differentiate it so that people will not confuse the two and realize that it's okay to get mental health checkups, and that's not necessarily because you're mentally ill.
Yeah, so the mental health part of it is really the well-being. You know, the mental illness is the diagnosis or the symptoms that are unmanageable. So, you know, just kind of helping people understand the differences between the two is that mental health is really teaching us how to cope, you know, how to get through life and meet life on life's terms. Where mental illness can be, now you need medications, now you may need inpatient treatment, now you may need a treatment plan. So if we're able to look at, you know, mental health is just a form of us being able to function better, to be more productive, how it affects how we think and feel, show up for the people in our lives, then, you know, that gives it a more, that's probably the simplest way to put it, to let people know that this, you know, wellness is really about, you know, health is really about wellness and well-being.
And I wanted to add to that, when individuals enter our office, on the door is our motto, the power of touch, physical, emotional, and spiritual. And one of the things that I've learned in medicine, and I've been practicing for 35 years, I am not going to be successful with helping someone with their hypertension if there is an emotional issue or if they are having difficulties in terms of their spiritual well-being. And so everything has to be taken together. And it is so important because we could do really well with controlling the diabetes, controlling the hypertension. But if there's an emotional stressor at home or on their job, we're not going to be successful. That individual is not going to feel healthy because there's an area of their life which has not been addressed. So we really do believe in that power of touch. And the other thing that power of touch says, there are so many people who walk into their physician offices, and I was told the doctor didn't even touch me. Well, you should have been touched either physically with listening to your heart with the stethoscope or emotional connection that I can trust what this physician is saying, or just given a sense that my spiritual growth does matter. My belief in God does matter. And that is going to help me to be successful overall, my total well-being.
Good. Anybody else comment on that?
I just want to say I have a hard time believing that Dr. Smith's been practicing for 35 years. You look good.
She's taking care of her physical and mental health. That's obvious. Okay. So when we, you know, I guess when I think in terms of when you say mental health, and as Dr. Smith said, sometimes I go in, the doctor doesn't say anything. If people look good, you know, like sometimes you go to the doctor and they'll say, oh, you look really good, and rush you through without really getting to something that you may look good on the surface, but there's something underneath that we're not touching. How can we as individuals get them to understand that they've got to go a little deeper from us and can't go by appearances, because the way things look is not always the way it is. Who wants to take on that? How can we do that?
Oh, so sorry. I was gonna say that's so true, because you cannot look at someone and measure their potential to cope with life stressors or, you know, their contribution to community. So you do have to go a little deeper and ask those questions. And the collaboration with the mental health clinician and our medical doctor, like Dr. Smith, is so important today.
That's right. And we're glad she extended her family practice to include that mental health part, the drug abuse and addictions and all that kind of stuff. So thank you, Dr. Smith.
And I'll add on to that because that is so important. We're actually in North Carolina. They were able to get a very large source of money, at least they have it today, in regard to collaboration. And so I actually work with a team with my team is providing the medical care. We do the screening, but then we do a warm handoff to a mental health professional who is going to do that second layer of screening and assist with creating that treatment plan. And I know we're getting into the next question a little bit. And I also work with a psychiatrist. Now, he's been practicing for 42 years. And so I work with a psychiatrist where we have an individual that may have that level of complexity. And this was a solution that was put into place because where I work, we have very few doctors in this community. And I mean less than 20 in this community of 60,000 people and our behavior health specialists. So there are strategies of what we call collaborative care, and I'm definitely appreciative of it. So I just wanted to mention that because we do see these solutions coming, and it's based on the trust, it's based on the relationship that the patient has with that practice setting.
Thank you. Anybody else want to comment on that? Okay, our next question. When choosing a treatment for mental health issue or illness, can counseling be chosen instead of medication, or can medication be used instead of counseling? Or particularly if a patient prefers one over the other, like some people may say, you know, I can do counseling, I don't need any medication. And some people say, I need medication, I don't need counseling. Can they make that preference, or should they be able to make that preference? Or should it be a combination of both?
I just want to jump in real quick because I think my mental health practitioners are going to love this one. I can admit that sometimes in dealing with our community members, just using the word counseling versus using the word therapy or treatment can do wonders in helping a person's attitude towards addressing what's going on with them mentally. In most of our encounters with patients, we have a very small window in which to build trust and get them to listen to us and receive some information that will empower them to make moves towards better health care. And it seems like the stigma lessens with saying you're going to talk to a counselor than saying you're going to go to a therapist, because we have more people that are so much more receptive to even listening to suggestions and making considerations. I think when it comes to medications, people often have a preference when it comes to taking medicine. Some people are like, I just don't want to take medicine at all for anything. But again, it's just like with physical ailments, getting them to understand that education, empowerment, and collaboration are the key elements to treatment and moving towards wellness in both your physical situations and your mental ones.
Anybody else?
Sure, I could absolutely jump in. So I think that the question made me smile just a bit. I do think that clients can choose to do whatever they want to do. And I think that is important for us to think about when we're thinking about Black women in particular, who've oftentimes been told that they must do what somebody else tells them to do. I think that the combination, if a client requires medication because of whatever the circumstance is in their life, if there is a chemical imbalance, if there are other things that are happening, then they should definitely take the medication. There are times when some people may not want to take the medication. And in that way, we need to be thinking about what are some of the different lifestyle and holistic changes that needs to be taking place as well. So for my clients, there is a preference that if they need medication, then they go ahead and take the medication. Taking the medication in the early part of treatment or in therapy can be helpful as well, just to kind of create a different level of balance and homeostasis. It's really difficult to treat a person when they're acute, right? But if they take the medication and that allows them to lessen some of the symptoms, then they're a little bit more open for some of the additional talk therapy and interventions that are in place there as well. But we do recognize that if there is a taboo connected to mental health, there is definitely a taboo connected to taking medication for mental health. So again, we have to talk about that with the client, use language that makes sense and is understandable to them, and help them to understand that this is just one part of the treatment. On the flip side of that, I do think that it is inappropriate for a client who has a mental health issue to only take medication. And I think that was part of your question. While there are people who believe that it actually doesn't help, the medication only helps with some of the chemical responses to that particular mental health or that mental illness or that mental disorder. But it does not treat whatever those life circumstances are. There are many times when we need to process and talk through what is going on in our life. There's many times where we need to understand that there is a person who is dedicating an hour to listen to us, to support us, to guide us, to ask us questions that can get us thinking. Medication alone cannot do that. So if a person is taking medication for mental illness, they should also be in therapy or in counseling. However, if a person is in counseling, they do not always have to take medication, depending on what their diagnosis is and depending on what their symptoms are.
Mhm. I agree with Dr. Plummer. Taking medication, the way I've explained it to clients is, the medication alone doesn't work. It's like taking a diet pill, but you're still going to McDonald's every day. If you're not changing your lifestyle, if you're not changing your environment, it's not going to be effective. So Ozempic will not work if you're not exercising and eating healthy. But when it comes to children, my approach is a little different because I do not use medication as the first line of defense when it comes to kids, because especially if a child is new to therapy, these symptoms may be presenting now. I like to work with families. I like to do like some interventions, get the family involved, assist them with making some changes in the child's environment, giving them different supports before resorting to medication. And I find that oftentimes, especially with Black children, the schools will recommend it. I went through it as a mother where my son was a little hyperactive in second grade, and they recommended a psychologist because he was, they considered him hyperactive. And he's probably the most calmest, quietest kid now. He's a teenager now. But at the time, he was just had that boy energy. And I knew my kid enough to know that that was not ADHD. So, it's important for parents to also, advocate for their kids and not always, take the advice of someone who may have met their kid for an hour, where they live with this child and they know that child day to day, their behaviors. So, just kind of looking at how we can approach it and effectively help people at different ages and different stages.
And I just wanted to add to this part of the discussion as well. Oftentimes, particularly people with substance use disorder, individuals who have difficulty with taking opiates or alcohol, we will get the request, can you just give me a buprenorphine strip? Can you just give me Suboxone? And then I'm going to leave. It's not going to work, because whatever the circumstances was that created that issue, it needs to be addressed. And I appreciate the therapy, the use of that terminology, but it needs to be addressed, or we are going to see failure and we're not going to see what you hope to achieve. So medication, while we have it, oftentimes that's not the sole answer. It does need to have the therapy, the lifestyle intervention, and other changes, modifications, if we're going to see true positive outcome and success.
Okay, thank you. Anybody else want to comment on that? If not, we have another question. How do we make those in the community aware of the wide ranges of resources that are available to treat mental illness and enhance mental health through self-care, like yoga, meditation, mindfulness, those kinds of things? How do we make people aware of those things?
I could jump in. I think we make them aware by going to where they are. So one of the things about Onyx is that we have multiple locations in different states and in different countries, so that we are able to access the folks that are there. And being able to do that, we can go to, a retirement community and have conversations that are there. We can go to a school and we can have conversations that are there. We can make videos on TikTok and also make videos on Facebook. And I mentioned the two because those are targeted to two different age groups, right? Facebook is for us Generation X and more mature, and then TikTok is designed for a lot of the younger folks. And so we need to go to where we see that they are. We know that a lot of folks are in the gaming communities, Let us have a booth at the gaming community, right? At one of the gaming conferences. We know that some of us like to shop. Onyx is at every fur convention. You hear what I'm saying? So let us go to where we know that the people that we are trying to be and talk to, let us go to them as opposed to expecting them to come to us. And when we go to them, let's make sure that our materials and our resources are accessible. Everybody doesn't want printouts. A lot of young folks are using QR codes and they're saving that information in their phones, right? So how do we make sure that we are using the materials that are supportive of who they are? It goes back to what we were saying before about the generations. You have to know who you're talking to, the language that they use, the resources that they use, the modalities and platforms that they use, and then make yourself visible there. And once you get their attention, be engaging, right? Like we are engaging folks as opposed to being monotone. So if you are talking to somebody else in your family about these services, be lively in the conversation. Don't make it so severe and serene that they're afraid to have the conversation with you. So make it the same kind of energy. And when you're asking somebody what they want on their Chipotle bowl, give them that same kind of energy. Where do you want to go to get your counseling, right? Who do you want to talk to? What are kind of the people that make you feel good? So again, making it more relatable, which means understanding who the audience is, where they are, the kind of language that they use, and making them feel safe and seen in those conversations as well.
And I wanted to highlight also, oftentimes providers of care don't know where the resources are. So one of the things that we've done, and any community can do this, we have a group that comes together the first Wednesday of the month. We have the military sitting at the table. We're very close to Fort Bragg military base in North Carolina. So we have a representative for the military community because oftentimes their families are not part of the discussion. We have the school system, we have the sheriff's department, we have private physician offices, we have the FQHC, and we're sitting at that table together at the health department, sharing our resources, sharing our information, and just getting it out there. And we started that with the opiate epidemic because we were seeing overdoses and deaths in the community. But when we came together, these providers of care, and shared that information. The other thing that we did, and this is with a group called the Old North State Medical Society, which is a similar to the National Medical Association, we mobilized, just as you said, and I like that QR suggestion because they're going to be at a Juneteenth celebration. And they have mobile vans that have information, and they will have our mental health team on those vans, and they will go to the celebrations throughout the state. So when people are eating the foods they probably shouldn't be eating, but they can also come and get more information in terms of that mental health. So getting out there, like you said, where people are. And one thing that I learned is so close to home, yet we forget that our own home, our own communities are lacking that information and resources. And that's something that we can do right here without having to go so far. You could do things right in your own community.
So I like to say I agree with both Dr. Plummer and Dr. Smith just said, bringing things to people. Part of the question was about self-care. When it comes to self-care and mental health, I think we need to it's nice to talk about massages and yoga, going to get your nails done, pampering yourself, even focusing on greatness. But some of the things that we really need to do are things that we can do internally right now. So when we talk about gratefulness, being intentional about how we demonstrate gratefulness by how we live, taking a truly introspective and honest approach to how we live and interact with others, and inventory. For those who thrive in social media spaces, being careful of comparisons, not living in a way that we say we're grateful for what we have, but we're constantly comparing ourselves to others. How many of us have spoken to people about no being a complete sentence? Well, it's a complete sentence when you're giving the message, so it should remain a complete sentence when you're receiving the message. Being careful to maintain safe spaces for people. Safe spaces for people to be themselves, like you want a safe space to be yourself. So within our faith communities, our jobs, our families, calling out others and talking to others about behavior that does not keep the space safe. Oh my goodness, you'd be so cute. You'd be so pretty if you just got your eyebrows done and put on some makeup. Who says that to people? We have people in our families that talk to other family members that way. Those things need to be addressed. In our faith communities, talking about safe spaces. Oh, let's lift Sister Tanya up in prayer. Her son done got locked up again. Did you need to add the last part? Because now the prayer circle's no longer safe because you told her business. We can keep her up in prayer without telling her business, therefore allowing that space to remain safe for her. We have a sister, soror, co-worker, or a cousin that always has the tea, right? How are you sure they're not spilling your tea to others? And if you're constantly living in that space, wondering if they're spilling your tea, you need to leave that space. It's not healthy for you. And one more thing, we should all learn to be a little less judgmental, not just towards others, but for ourselves. A lot of how we live, decisions that we make are based off of judgment or perceived judgment or preventing judgment. Because let's just face it, we done talked about other people and had opinions about what other people done, said, read, wore, everything. And what we decide to do a lot of times is in fear of what people will have to say about us. Will they be able to turn around and say the same thing about us that we just laughed about? So remembering to extend grace the way we would want to receive grace, all of that is a form of self-care that will allow us to nurture ourselves mentally.
And Terry, I just want to share an experience because you just triggered something in me when you talked about people being judgmental. So, in mental health, it's a nonpartisan issue. Everybody agrees that mental health is necessary. But when you get involved in politics, it is a numbers game, and people their job is to make you look like a bad person so they can win. That's just how it works, right? So the one thing that I was told by a counselor that really helped me stay focused on the mission and not get distracted by the smear campaigns and all the craziness that goes on behind the scenes, because that is how the sausage is made, y'all. But a counselor told me, they said, Latoya, people have two things, excuse my French, y'all, but I was told people have two things, assholes and opinions, and they both stink. That's it. That right there, that was all I needed to hear to know that, you know what? Everybody's going to have an opinion of you. Don't let their opinion affect how you move and how you feel about yourself, because their opinions stink, along with that other thing that I mentioned.
Okay, thank you. Something that you want to bring up, which we haven't touched on, mental health care has to be paid for. In a lot of instances, insurance doesn't cover it, or it covers it for a very short period of time. Can somebody address that? Because I think that interferes with some people's ability or willingness to seek care.
I think I was gonna say insurance does cover it, and it will cover it for some time. When you talk about inpatient and substance use and things of that nature, there may, be some differences with inpatient, but it will cover it. It's just that as a practitioner and the provider aspect of it, it can be very challenging navigating through utilizing insurance and also educating the patient or the client and letting them know that if you want to utilize your insurance, I'm required to give you a mental health diagnosis, and it has to happen at that first meeting. Unfortunately, that's just the way it is. So I have clients who, or people who have inquired about mental health services, and they struggle with that, but it's just the way it is. And many people don't want to pay the out-of-pocket fees that they would incur if they do not use insurance. But that's one of the challenges I think that a lot of the public or society just does not understand how insurance operates and what we get in return for the services. Sometimes it doesn't meet.
I like to add on as well. So under the Obama administration, there were a lot of changes that occurred with insurance and mental health in particular. And a lot of those policies are still in place, and a lot of the insurance companies are still adhering to them. However, it is there was information for many years prior to that that insurance companies were not covering mental health services. That is not true. The insurance companies do cover mental health services. They have to be coded in a particular way. And like Maisha just mentioned, there has to be a diagnosis in that first session. The diagnosis in that first session can eventually be changed. So in Onyx, there is one diagnosis that we use as clients are beginning their services. We take 6 weeks to build out a full case conceptualization and a treatment plan to make sure that we're given an accurate diagnosis, and then we change the diagnosis. We also work with a Black woman-owned billing company who handles a lot of that information. They are specialists in their field. I am a mental health specialist. I am a professor. I am a speaker. That is what I do. I do not do billing, right? And so I have to let people who work in their lane continue to excel in their lane and not try to cross over into their lane. So it is important that when a person is seeking mental health therapy, if they have any questions, that they ask the provider to give them that information or to connect them with someone who can give them that information. The insurance companies also have direct lines, and some of them have direct lines for mental health, where they are able to say, this is what your coverage is, this is your copay, this is your co-insurance, this is your deductible. And they can also give a list of providers that accept that insurance in that particular zip code or with particular demographics that they're looking for. So it is important to dispel that myth. A lot of private practices and nonprofits also have sliding scales. So they can look at a person's income, or they can assess a few things and reduce an out-of-pay cost, or even reduce having them pay for their copayment or their co-insurance. So the insurance is not as much of a barrier as it was 15 years ago. It is a lot more easy to navigate and to get the support that we need.
Anybody else?
I wanted to add, before people choose insurance, they may want to ask questions about mental health, behavioral health, and substance use coverage, because all insurances are not created equal. So you may find you pick one plan and you may have a higher copay or co-insurance with that plan versus choosing something else where you may have a higher monthly payment. But so you have to really educate yourself on choosing the best plan for what you and your family may need.
Okay. Anybody else from that? Oh, we are winding down. So basically this ends the prepared portion of the questions tonight. So we want to, at this point, we've had an eye-opening discussion. Everybody's done an excellent job giving people a lot of food for thought, a lot of information that we can take out into the community. So at this point, let's get some questions from the chat, hear what the participants, what they'd like to do.
So there was a question that I would like to be able to maybe kick this portion off with. There was a question in the chat around how do we address the stigma and the services for Black men in particular. And I think that that's a really important and powerful question, particularly because we've talked about the generations and we've talked about culture within generations. But there's also a culture that is connected to our gender. Women are oftentimes encouraged to talk a little bit more with their friends, with their family. Part of that is related to human development and how our brains develop quicker in those language and development and social interactions. Whereas many men have been socialized to stay quiet or to not talk about mental health and fear of weakness. So I think that when it comes to mental health services and really encouraging our Black men to participate in therapy, we need to be able to, again, use the language that they're most familiar with. And we can also use very specific resources. In this area, the DC, Maryland, Virginia area, there are several practices that are dedicated to working with Black men. One of those practices is Minds in Motion, and they are in Laurel, Maryland. and they are all Black men, similar to Onyx being predominantly Black women. They are all Black men that are providing direct services to men in person and virtually as well. I think there's another resource called Therapy for Black Men. That's an online website similar to Therapy for Black Girls. But Therapy for Black Men has a list of resources and a list of providers who specialize in working with Black men as well.
Sora, I would like to add to what Dr. Plummer said. One of the challenges in our community with Black men is that since slavery, our Black men have been emasculated, and that's actually been handed down through generations. And many of our Black women, unfortunately, continue on with that tradition. And our Black men have also not been afforded the same opportunity to address their mental health issues, and this is back in the slavery area, as their white counterparts. So, and then when they tried to escape slavery, many times they were diagnosed with schizophrenia, and it was not a diagnosis based on their mental status. It was based on their behavior, their actions of trying to get away and escaping slavery. So a lot of that mentality and behavior, thoughts, etc., have been handed down through generations. And that's something that we actually don't talk about much in our families and in our homes. I researched that while I was preparing for a film on mental health. And that's how I found out. So it gave me a different understanding of why Black men have a fear of getting help and why sometimes they may not want to sit in front of us Black women and get help because of how many times we have treated them or have learned how to treat them. And that's just something that I would like, to mention, and hopefully that can change.
So Sora, Joanne, and I were at a women's empowerment event over the weekend at a church in Annapolis, and the room was full of mostly women, but there were a couple of men at this conference. And when I did my portion on mental health and trauma, um, I I was intentional about recognizing the men in the room to make sure that they were seen. And there was one gentleman there who was, I don't know, Sir Joanne looked like he could have been in his 60s, but he was an older gentleman. But it got to a point where he got comfortable enough in the workshop, and he first started off by saying, I know this is a women's conference, but I just want to speak on behalf of men. And what he shared, and then he started to share little personal things about his upbringing, not having a father. And I think we as women, because our field is dominated by women, I think that we should be more intentional about being more accepting of men and allowing them to feel vulnerable and comfortable with opening up to us. And because that makes a huge difference when we come in with that attitude. And we have to just respect Black men. They don't feel respected, not just by white people, by Black women. Let's be honest. A lot of them feel like we don't support them. And we now need to start being more intentional about respecting our Black men, looking at them as leaders, looking at them as heads of our households, shutting our mouth, listening to them, and not allowing them to just constantly be in a world where everywhere they turn, they're ignored, or they're not respected, or they're not valued.
It's interesting that you said that because I take care of a lot of our military, particularly retirees, and I have to ask them, was your post-traumatic stress disorder, was it when you were in active service on the field, or was it when you came home? And that's what we see. So this is really highlighted that where is the trauma? And we need to recognize that and let them speak in terms of what is going on today.
Okay, thank you. Sir Marcia, do you want to continue with the chat questions since the prepared questions have been addressed?
Yes, I'd like to go to the next one. The next question is from someone who's in the Annapolis community, and they'd like to circle back to self-diagnosis. They're part of the younger generation, and they want to know how can their peers and them break the stigma when social media seems to increase societal pressure to hide any mental health struggles? So, Congolo, can you address that?
Yes. So I first like to tell I know that they use TikTok and Instagram, but oftentimes I tell them that just Facebook is really fake book. You know, the truth is that we put our best representative online. We don't put the vulnerable us. We don't put the us on a bad day. We highlight the best part of ourselves. And if we can just help people get into that mindset that the purpose of social media, the purpose of media, is for you to drink the Kool-Aid, and the Kool-Aid is made of toilet water. It is not
Hmm.
real. This is not the reality that we live in. You should not go on social media and envy anybody, because they're showing you the part of them that is, the best version, where we all have vulnerabilities, we all have something, we all have struggles, but we're not going to put that on display. That's not natural for us to do. What we're going to do is put out the version of ourselves that make us look good, like we got it all together, and none of us have it all together. So we really need to just help people just look at that, and kind of, when you go on social media, approach it with that mindset that we all have something.
Anyone else?
I think that, it's important to stay within community. So adding on to what Sora Latoya said, social media is for entertainment. And yes, there are times when you can get new information from there as well. But when one is dealing with conversations around mental health and mental illness, those conversations can happen in your community with the people who are close to you, in your villages. So you don't necessarily need to use social media to break the stigma. You could just have a conversation with your homegirl or your homeboy. You could talk to your auntie and your uncle. You could go to your godparents, and just have some of those conversations. And because we mentioned that this particular audience member said that she's a young person, if you are still in dating age, make sure, or dating experience. Let me not say dating age, because some of us are outside. But if you are still in that particular stage of life, make sure that you're asking these questions early on in the dating conversations as well. Making sure you're asking people how they approach mental health, how they approach mental illness, how they've dealt with people in their families who've had mental illness and mental health as well. So breaking the stigma doesn't necessarily have to be through social media. It can actually be and more impactful in conversation, one-on-one conversations or small group conversations. Some of the suggestions that I have for folks is to invite all your friends over and you guys do some conversation bowls. And you all are just hanging out and you're communicating, you're bringing forth ideas. If you are in a book club, read a couple books that are around mental health and discuss that as a book club. If you are in different environments, just bring those kind of conversations up there and don't rely on social media to help you break the stigma. Do that in person with people.
Anyone else? Okay, thank you. Well, the next question is from me. I have an uncle who suffers from bipolar disorder, and most of the time he refuses to take his medication. And that's probably wrapped up in the stigma of the illness itself. And this has resulted in his becoming unhoused, living on the streets, and completely unhealthy. What can my family do to help him?
Uh, I'm sure the panelists will have something else to say, but I just wanted to mention briefly that medication compliance is very difficult. It's one of the most difficult things for someone that has bipolar disorder. So I just wanted to let the family know that it may be focusing solely on that, not saying that that's what you do, but I understand that you want them to take their medication. And I've had many clients with diagnosed with bipolar disorder, who had very challenging times with staying compliant, with the medication, and it's because of the ups and downs and what happens with their brain. And I will, allow the other panelists to speak on that more, but that is definitely one of the characteristics of that disorder.
I'd like to offer a resource because untreated severe mental illness is very taxing on the family, and I've seen families live like prisoners in their own homes. And I when I started in this field, I started in the mid '90s, and I remember when we were transitioning people out of psychiatric hospitals, long-term stays, into the community. And if I'm going to be honest with you, and not saying this directly to Sora Marsha's family member, but there are people in our society who really should be in long-term treatment, who really are not fit to function in society. And we're seeing more and more of those people. And guess what? Those people are now having children or even grandchildren at this point. So we have to understand that the first risk factor here is genetics. So, we have to look at the fact that there are people that may need that 24/7 supervised support. And I think that we need to acknowledge that there are more people than not that require that support. Um, and the other thing I would like to recommend is NAMI, which is the National Association of Mental Illness. So they have a family support program. They have a 12-week family program where you can become certified to become a family peer. But those programs are really helpful because families need to recover as well. This isn't just about the individual. This is about recognizing that family members need to heal. They need resources. They need support. They need a better understanding of these symptoms and how they can be a good support to their loved ones.
And really quickly, Sora Marshall, I was going to add, if your family is ever able to get to an appointment with him, if he allows it, I would speak with the prescriber and talk to them about the side effects, if he's experiencing anything about the medication, and see if he's on the most appropriate medication for his DNA.
Mhm. Thank you. Okay, also had another question. I have lots of questions. When my son was young, I thought he might have ADD, but I was unsure and I didn't know where to turn for help. Additionally, so many were being diagnosed at that time that I worried he might be prescribed medication in haste. Now he's been diagnosed with ADHD as an adult. How could I have addressed this earlier and escaped the self-imposed stigma?
I'm careful as I answer this question. I believe in Kairos, which is divine time, spiritual time. And I think that we find certain information when we're supposed to find that information. So the question, as it sounds, is really about what could have been done in the past. And I don't know if we should spend a lot of time thinking about what could have been done in the past versus appreciating what is happening now and using what is happening now as a catalyst or a springboard to help other people. So for that particular soror, this may be an opportunity for you to educate other parents. As you could tell, I'm really big into the community. So if you're part of parenting groups or if you're part of mother groups, if you have other children in your family, talk to the people that are nearby and share your experiences with them. That way, you're able to use that challenging time that you had, maybe even that pain that you had, to actually empower someone else. So again, I'm not a person that, as a therapist, I have to spend time thinking about the past and talking about the past. But in this particular context, I do believe that it is probably more effective to think about how you can use that experience to help others.
And Sora Marsha, I really, really appreciate you opening up and sharing that with us. And what you're describing is what I hear from a lot of parents is, what could I have done differently? What if I could have, would have, should have? I had a mom tell me once, if I had only breastfed, my child wouldn't be struggling the way they are. And it's natural for us as moms to look at what we could have done differently. And there's really no guarantee that anything would have been better or, had you had some sort of intervention early on. But these are some of the questions that often come up in NAMI, in the family support groups. And I think that if you were to attend those meetings, you'll find that more parents think like you than not, and can share in those feelings that you're expressing.
Thank you. Check and see if there are any more in the chat. Okay, I don't see any more questions in the chat. Okay. So I've posted a survey in the chat, and I'm asking everyone to complete the survey if they can. I want to thank all of the guests who who joined us today and making yours and others' mental health a priority during the month of May, which is Mental Health Awareness Month. And I want to give an extra special thanks to our panelists who donated their time, their knowledge, and their wisdom about the subject matter. President Peters, do you have any closing remarks? I don't know if she's on. If you're on still, you're on mute. Okay, I don't know if she's available at this time, but once again, I'd like to thank everyone that joined us, and thank you so much to all of our wonderful, wonderful panelists today, and to the Physical and Mental Health Committee who made this happen, and to all of the sorority sisters in the Annapolis Alumni Chapter. And that ends our webinar for today. Thank you so much, everyone.
Thank you, Soros. Thank you, everyone. Have a good night.
Good night, Soars. Happy Mental Health Month.